other conditions. So for example, it's hypertension, myocardial infarction, which aka heart attack, strokes, and eventually those things will actually lead to chronic kidney disease. And so when we think of heart disease, the first thing I'm asking, ask the patient as well, do you suffer from high blood pressure or hypertension? What is your family history? What are you eating at home? What are your activities that you do at home? Are you smoking cigarettes? Do you drink alcohol? Are you active? So those are the things that really makes a difference when it comes down to treatment in persons that are suffering from cardiovascular diseases, especially African American women, because again, women's health is not a priority in our country. Black women should be concerned because cardiovascular diseases kill roughly about 50,000 African American women annually. By the time an African American woman becomes 20 years old, she is at increased risk for developing heart disease. The thing is about cardiovascular disease, it affects all women. The problem is that amongst African American women, it's underdiagnosed or misdiagnosed. Many of us are coming into the emergency room at a very young age with chest pain, shortness of breath, high blood pressure, and that's very concerning. Signs are shortness of breath, dizziness, heart palpitations, not really generalized weakness. Some people feel numbness on the left side or the right side of the body, or they develop headaches. So once you develop any of those symptoms, you gotta come to the emergency department. Call 911 and go to the emergency department immediately so you can get further workup, because you may be impending a stroke or a heart attack. The first treatment that we like to propose to patients is actually changing their lifestyle. Get rid of the cigarettes, decrease the consumption of alcohol, cook, develop healthy cooking skills, just promoting eating better. I mean, that's really, eating healthy and decreasing the consumption of red meat and increasing your intake of fruits and vegetables and bran. It goes a long way, because food is medicine as well. But it depends on what kind of food that you're putting in your body that can actually destroy you at the same time. So this is what we gotta do.
Okay, good evening, everybody. I do apologize for those who could not hear. It was interesting. Some of you were typing in the chat box that you could hear, and then others were typing that you couldn't hear. That's interesting. I'm not quite sure what to make of that. Half the side of the table is here and half the side is not. But we'll work it out. As many of you know, this is just the day 2 of us using this new platform. We were with Zoom for the last 5 weeks and thought, hey, let's try something different. This particular platform has a lot of features that we particularly enjoy, and so give us through the weekend to figure out all the kinks, but we'll work through it. You're joining us tonight for part 2 of an incredible 2-night series on women's health. We talked on Tuesday with Dr. Otley and Dr. Cruton around women's health, particularly related to maternal health and women who are having babies, and Black women being the highest number of women to die because of pregnancy. And so we got a lot of great information from Dr. Cruton and Dr. Otley on Tuesday. And tonight we are taking this conversation into part 2, which really deals with the leading causes of death for women of color. And maybe some of this tonight is going to surprise a few of you, and maybe some of it won't surprise some of you. But I will say, in my research, I've been looking at this information and reading some statistics and watching videos all week, and I am super surprised. And as an educated individual, that surprise must mean that this is not information that is often discussed. And so we want to make sure that we use this space here on our Village in Action web series to bring you information that is up to date, information from top experts across the globe to talk about some of the issues that affect our community. And I'm going to ask for Dr. Negin Mokhtari and Dr. Doris Berkey to turn their cameras on. I want to introduce them. I want them to also turn the mics on and introduce them as well as we get started with tonight, conversation around women's health. Dr. Nagin Mokhtari is a maternal fetal medicine fellow in the Washington, D.C. area. Her area of expertise is women's health. And Dr. Doris Berkey is a family nurse practitioner and primary care rural health care in West Virginia. Both of them are joining us tonight to talk about women's health. Dr. Nagin and Dr. Doris, great to have you on tonight.
Thank you. Are you able to see me?
Not yet. Dr. Doris and Dr. Nagin, you can turn your cameras on so we both can see you. Okay. I see you, Dr. Doris. Can you hear me? Maybe her mic is muted.
Hello?
I can hear you, Dr. Nagin.
Okay, I just can't see myself and I'm pushing that icon. I'm sorry.
Okay, no worries.
Black screen, unfortunately.
Jason, can you hear me?
I can, Dr. Doris. Can you hear me?
I can't hear you.
Oh, okay. Is there a way that you...
Everybody calm down.
Hello?
All right, Dr. Nagin, can you hear me?
Yes, I can.
Okay, Dr. Doris, can you hear me? Dr. Doris cannot hear me yet. Yeah, see, I wonder if she probably has something that she has to unmute. But Dr. Nagin, good to see you. Glad you got your camera working.
Yes, it kind of logged me out and brought me back in. So
Okay.
hello to everyone on the line.
They were all in the chat box. We would restart the chat because we lost their chat messages earlier.
Yeah, I see Doris talking, but we can't hear her.
I can hear everyone now.
Okay, we hear you.
Oh,
Sorry, it took a minute. I couldn't hear anything.
no, it's all good. Hey, it's technology, you know, and everything will be all good. Well, Dr. Doris, Dr. Nagin, it's great to have you both tonight. We do know that the hour is after 8, and we do want to kind of get through some of these questions. I do appreciate both of your sacrifice. I know that you both work a majority of days of the week, and so to come home and jump on another call after finishing work, can be a little tiresome. So thank you both for your sacrifice. I do want to just read a few stats that I have pulled from some literature this week, and then I want to get into some of these questions. Cardiovascular diseases, it kills nearly 50,000 African American women annually. I thought that was a very, very large number. Of African American women ages 20 and older, 49% have heart disease. That's something that I want to talk about more tonight. Only 1 in 5 African American women believes she is personally at risk. Only 52% of African American women are aware of the signs and symptoms of a heart attack. And then the last statistic I pulled was only 36% of African American women know that heart disease is their greatest health risk, which kind of makes me wonder, Dr. Nagin and Dr. Doris, how much conversation around cardiovascular disease, around cancer, and around strokes are physicians having with African American women, which are the 3 leading causes of death. So I want to just have kind of a roundtable discussion. Dr. Doris, Dr. Nagin, imagine that you're at my dinner table tonight. And so I want you to kind of, sit back, get a little bit comfortable. I know that, some of these questions are a little daunting for some of us to hear, but I certainly want both of you to keep it, as we say in the community, keep it 100, keep it real. And so question number one, and feel free, either one of you, to answer. The leading causes of death among Black women in the United States includes the three I mentioned earlier: heart disease, cancer, and stroke. Why are these three so prevalent within the Black community, specifically African American women?
Oh no.
Uh-oh. Doris, your mic.
Am I on?
Yeah,
Okay.
there it is.
What I have found in primary care, which is where I work in a rural clinic, and what I know from my schooling and different things and the research out there, are that hypertension is one of the leading problems in Black women. As high as 45% have hypertension. Hypertension leads to heart disease. So, and some of the cancers that are out there that they're susceptible to, that they're at higher risk than whites and some of the other minorities, are, breast cancer, colon cancer, lung cancer, and cervical cancer. And what I have found, because in Black women, hypertension occurs a lot earlier in life than it does in most of the white population. So many times it goes unnoticed because it can occur very easily in the teenage years. So these women don't always know that they even have a problem. And, we in the primary care field call hypertension the, what is it? I'm trying to think what we call it. The
Silent killer.
The silent killer. Thank you, Magin. The silent killer. So many people have no idea they have it. And smoking rates in Black women have increased significantly. 1 in 5 smoke. That puts them at very high risk for the different cancers, especially lung cancer. And the thing with hypertension with Black women, they are very resistant to many medications. We do not start Black women out on the same medications that we would start white women out on. And, if their primary care provider, for whatever reason, doesn't know that could become a problem, obviously.
And I would just add, I think all those risk factors are the top causes of death are all related to obesity too. So, I was reading a startling thing that obesity is a BMI greater than 30 or 25, actually. Overweight's greater than 25 and obesity is 30, which we consider normal. And that's 90% of the population almost.
Mm-hmm.
That's a lot. And if that's contributing to that's contributing to cancer, hypertension, stroke, that's why we're going to have the, unfortunately, bad outcomes. And I think that comes as one of the parts, as well as hypertension. We are trying to be better at it by changing the definitions all the time. So if you have ever heard blood pressure 140 over 90 is considered blood pressure, now that number has come down to 120 over 80 as being less than that is normal. And anything above that is considered pre-hypertension or even hypertension. So because we know that this is a silent killer and contributes to cancer, contributes to strokes, heart attacks. That's why we take it so seriously and we try to change all those things. But again, obesity is also related to all of this too.
Dr. Negin, let me ask you a question because I'm glad you brought the obesity piece up. I've also read some articles about BMI and is this a myth? Let me know if it is, because when I go in to get my BMI test, as a Black male, my physique, my bone structure, I've always been told that, Black people just have stronger bones, right? Wider physiques. And so the BMI is really a test for white individuals, not Blacks. Is that a myth? Talk more about that.
I wouldn't say that. Yes, I wouldn't say that we can't apply BMI to Black individuals compared to like body shape and, you know, skeleton. I know that there's some talks of their skeletons being different in weight distribution. But BMI has still been validated in the Black population for outcomes. So we, as physicians, we get a BMI, but then we look at the patient. So it's based on height and weight, right? So if you're super, super tall, if your weight is distributed in a certain way, so we don't like the pear, you know, the pear shape versus the apple shape. If you're an apple shape and have a more round, you know, belly area, that's worse for heart disease. That's worse for strokes. Compared to the pear where the thighs are a little bit bigger. I mean, I'm not saying that it's better to be that way, but that fat distribution is not going to cause as significant health problems to, if you can imagine, all that belly fat is pushing up on your heart, making it hard to breathe. You get sleep apnea. You can't sleep at night. You snore. Those are all leading to all those things. So I think BMI actually is very important and should be calculated for everyone, and shouldn't say just because you're you know, sometimes muscle builders, right? So like very football players have a high BMI, but it's kind of distributed differently. So I think muscle and fat distribution is also important in part of that calculation.
Yeah, I'm glad you talked about the BMI. I mean, as a male, and this is not about me tonight, so I'm not going to talk about me much, but as a male, I've always been told that my BMI is super high, right? And so this muscle and mass, and, you know, so this is just good to hear so that we understand BMI matters. I think that we have either convinced ourselves that BMI doesn't matter, or we've allowed somebody else. And this is the reason why we have you physicians on, because I'm tired of hearing the opinions of folks who've not gone to medical school, right? We have to do a better job of that. Another question around research that I found this week, it shows that African American women have a strong family history of high blood pressure and heart disease. And so why are Black women predisposed to high blood pressure and heart disease versus other women? And then the second part, you guys could tag team. What interventions or advice do you share with your African American patients who do come in with high blood pressure and heart disease?
Well, I certainly, there is a strong family history. And one of the things that I always tell all of my patients, but especially the Black population, is you've got to know your family history. You've got to write it down. You've got to make sure your children know it, your grandchildren know it. It's really, really important, because there is a genetic disposition with hypertension and heart disease in families. So, you know, and there are certain, and we'll get to that a little bit later, but certain screening methods that are different for Black women versus white women because of some of their family history.
I would also say, in terms of family history, I mean, if you're living in the same household, right, you're going to be eating the same things. You're going to be doing the same things. You might be sitting on the couch more, you know, or, you know, not exercising because your mom didn't do it. So I think it's not only the genetic disposition, but environmentally, it's also the same. So if that's the way you were raised, you're probably going to continue raising your children that way, and it becomes a perpetual cycle. So I think it's super important that you also know not only your family history, but also know what are good and bad habits, which we'll talk about later, of what are good and bad habits to keep and versus not. And I think that comes from just not knowing, or talking to some people who don't know, right? Or hearing it, you know, like the myths that people say, like old wives' tales. So I think it's super important that we kind of hone in on that as well, and just know that it's not just genetics, but also your environment.
Right. And you're exactly right. If you're used to eating fried foods all the time, if you're used to eating a lot of pasta because maybe you're a low income family and it's cheaper, that's what you were raised on. That's what you make for yourself. That's what you make for your children. And it goes right down the family. You're exactly right.
Talk a little bit about the importance of exercise, right? We hear these 20 minutes a day or 30 minutes a day, but you're both are right. If you weren't raised in a household that did a lot of exercise, right, then you are not thinking about exercise. You go to the doctors once or twice a year for a checkup. Your physician tells you you need to exercise, and then 11 months have gone by and you haven't. And then you go back again. Physician says you need to exercise. So both of you talk about how important exercise plays into that equation to lower the risk of heart disease, to lower the risk of strokes and cancers.
I mean, we definitely see exercise improves all of those things. So high blood pressure, cancer, it eliminates the waste in your body, and especially heart disease, stroke. So I would say that exercise should be like brushing your teeth. If you get up and don't brush your teeth, then we need to talk first. But also, we also need to talk about how that needs to be part of your daily routine. Even if you say you don't have time, you've been working 3 jobs, you know, you can't do it. Make time for yourself, even 5 minutes, to increase your heart rate, to increase that metabolic demand so that you are burning calories. So you are working your heart and trying to get all those toxins out of your body. What I say to my patients is that it's not possible to sometimes exercise every day. I will tell you, I don't exercise every day. But if you can get your heart pumping 30 minutes, 3 times a week at first, I think that's a start, because you're going to head in the right direction rather than sitting on the couch and watching Netflix. So I think if you can make it a chore for yourself, just like how you brush your teeth, just like how you take a shower, like how you change your clothes, if you can give yourself that 15 to 20 minutes initially and then build up to it, it will become a habit in which you can't break anymore. It will become a lifestyle routine that you have to do. So it won't become a chore anymore. It will become a habit. And I like someone said, take stairs instead of elevator. Yes. Or park your car far away from the entrance. Make yourself walk. Those are all ways to kind of increase that.
And I think starting out, you know, with people that don't exercise, I have them start out slow. Exactly. You know, like you said, I have them start out, you know, 5 or 10 minutes of walking, you know, just a couple of times a week, and slowly increase it. What you're aiming for is 150 minutes a week. If it can't be daily, if it can be 3 times a week, 5 times a week, but the goal now is 150 minutes a week. Stop and think about that. That's only 2.5 hours, give or take. You know, to make your life better, to make the chances of you having a heart attack, stroke, you know, losing weight and exercising that heart makes a big difference.
And I will say, you don't have to just go on elliptical. You don't have to walk. I love dancing. I love Zumba. I don't know if anyone's done it, but it's super fun. And it makes it so you don't realize that you're exercising, right? You think that you're having fun instead. So if you like dancing, go. I mean, I know with COVID right now, things are different, but go to a club, dance off, you know, your booty. So try to make it fun.
Yeah, that's great. And I love that you mentioned, I wrote this down in the chat, you know, exercise is like brushing your teeth, right? That is the one routine that I don't care if it's a weekend and I'm not going anywhere, I will still get up and brush my teeth. You know what I mean? So I think that we have to really think about exercise and brushing our teeth, how synonymous they have to be. Not that they should be, it's they have to be. And a lot of times I think we are so comfortable, Dr. Doris and Dr. Negin, living in the right now, that we're not thinking about a few years from now. And sometimes selfishly, we're thinking about, well, I've lived a good life, but we're not thinking about all the other people in our lives who would be saddened if we left too soon, right? So I think there's a responsibility there. I do appreciate you both for sharing that. Another question about some research that I looked up this week about the effects of salt. Researchers have found that there may be a gene that makes African Americans much more sensitive to the effects of salt, which in turn increases the risk for developing high blood pressure. I'm curious to know if either of you are familiar with this gene, if this does exist, and if so, can you expound on more and just talk about the effects of salt on our bodies?
You want to take this?
Well, I don't know a huge amount about it, but I actually read a research article not too long ago, and there are a couple of genes that are looking at that alter the sodium in the kidneys in Black women, and sodium kind of equivalents to salt to everyday people, and sodium in the kidneys, I'm trying to think of the easiest way to explain it, helps to regulate the blood pressure. There's a mechanism that occurs in the kidneys that regulates the blood pressure, and this sodium is a part of that. And from what I gathered from the article that I read, Black women tend to retain more of the sodium rather than letting go of it like white women do, and this can cause the blood pressure to elevate. I don't know, Nagin, if you know more about it. That's about all I really know about it.
So
Um,
the literature is basically that there is some genes. I don't think it's just one.
right.
Predisposes the African American population to this. But I don't think we have a target that we can target it by any means with medication. And so the biggest thing is, food has to taste good, right? But we also need to know that moderation is key. So using things that don't have a lot of sodium. So I know like Mrs. Dash or things like that. So some of those things. And also looking at your ingredients. I think it's super important, just like how I told you guys about exercising, just like brushing your teeth, looking at labels on your foods. You have to know the percentages. If it seems high, don't take it. That's not good. Or you can have a treat every once in a while, but you have to look at labels. And so I think that's an important habit too, of looking at calories, looking at carbs, looking at sodium and the percentages, because it will tell you there what is the percentage of daily value. If you have 2 bottles of Coke, you're at 60% almost of your sodium.
Jeez.
Well, I think it's interesting, Nagin, that you hold up a bottle of water. And I have to tell you something interesting that I learned back some time ago. That's all I drink is water. And I couldn't figure out why I was drinking so much water. And come to find out, I was drinking a brand of water. I won't mention brands, but I was drinking a brand of water that had sodium in it.
Yeah.
Tasted great, but the more I drank, the more I wanted. So I changed to a brand that does not have sodium in it. Most natural, that says natural spring water, most of those do not have sodium in them, or salt, if you want to say. Those are much, much better for people to drink than the ones that are enhanced with sodium. Makes it taste a little bit better, but it's really not good for you.
I had 2 kidney stones in the last 8 years, and the pain in both of those stones has made me probably 70% of what I consume liquid is water, because I am afraid of going back to the hospital and getting IVs and getting that pumped out of me. That pain is so unbearable, right? And so I know that, and both of the stones were because of sodium chloride. They told me after the stone passed that it wasn't calcium, it was sodium. So I hear how important it is to look at the labels. What is the average intake of salt per day? And the reason I ask is because we can look at the labels, but I'm also thinking about the Black community who loves Popeyes, who loves KFC, who loves some of these, Church's chicken. We fry chicken, a couple times a week, or I love fried chicken, but it's the sodium I'm hearing that's too much, right? So if you could talk about how much of that we can have per day so that we can begin thinking about what we intake for the week.
So for a healthy person who has no medical problems, which is none of us, right? We all fit into some kind of category. It would be 2 grams. Okay. So that's half a teaspoon. If you have any medical problems, I would recommend 1,000 milligrams or 1 gram. Most Americans, including African Americans, take about 3.5 to 4 grams. So double and triple of what is supposed to happen.
Okay. Wow.
Just look at your Coke bottles and you'll see. You look at your chips bags. Unfortunately, we meet that criteria with just one meal.
Look at canned vegetables, how much sodium is in canned vegetables. You should eat fresh or frozen. It's unreal if you start looking at labels, how much sodium is actually in things.
Yeah. Let me ask this really quick. So for some of our low income families who may not be able to afford to go to a Harris Teeter or a Trader Joe's or a Wegmans and get fresh produce every day, right? But can afford a $1 menu at a drive-through. What advice do you give to those families when it comes to sodium and they can't afford some of the fresh produce?
It's hard. It's definitely, we know these food deserts. We understand that, a candy bar is much cheaper than an apple. I think, but the biggest thing is if you can kind of, like, let's say that you're getting a sandwich, removing the breaded pieces of your chicken, removing one of the buns, making the soda, instead of a soda, get a water. If you have to do vegetables, ask them, or if you get French fries, even ask them for no salt. If you get vegetables, make sure that you dab it dry. Try to get off the seasonings as much as you can, even though, if you have to do it, you have to do it, but you try to make it as healthy as you can for yourself as much as you can, and try to supplement as much as you can.
Speaking of social barriers, cancer is the second leading causes of death. And Dr. Negin, you and I spoke this week about a term new to me, cancer surveillance. And I looked it up. Cancer surveillance is the ongoing, timely, and systematic collection and analysis of information on new cancer causes, event of disease, screening tests, etc. Research shows that breast cancer tends to be a more biologically aggressive disease in Black women than in white women, which also reflects social barriers, whether that's perceived invulnerability for beliefs and a general mistrust of the healthcare system. So with these perceived invulnerabilities, these social barriers that exist between Black women and the healthcare system, and we're now talking about cancer, how do we reduce those social barriers?
I think
Go ahead.
I think it's education. It's knowing that doctors are not out to get you. Healthcare providers are not out to, make it worse for you. I have patients who tell me, like, I don't trust the healthcare system. My family died here. My mom died here. And it comes from trust, and it comes from finding a provider you trust in. So it's okay to provider shop. It's okay to go to different providers and see who you feel comfortable with. I always encourage a second opinion. I always encourage you to see someone that you feel comfortable with. And I think that's what the main thing is. If you find a provider that you feel comfortable with, I think that barrier will go away because you will trust that person to make the best decisions with you. It's shared.
Right, and I exactly agree. I think the education, there are free services out there for breast and cervical cancer screenings. Health departments offer a lot of that free. There are federally qualified healthcare centers. We have those all around here that see patients. If they don't have any insurance, they don't refuse to see them. And we have ways that we can get mammograms paid for very often, and pap smears, paid for. So, trying to get that information out is the key, that, we can help you if you just come to see us, you just pick up the phone. There are lots of, we have a lot of ways that we can get you plugged in with people, and ways to get you the stuff the screenings and the things that you need. Can you
talk more about the screenings? Because I love that you said there's these free screenings, right? I love when I hear that healthcare can be provided to the communities for free. And so I know you're in West Virginia, so talk about where people who maybe in that area can find it. And Dr. Negin, you're in the DC, Maryland, Virginia area. Where can women go for free screenings?
So free screenings can be in West Virginia, can be obtained at any health department. They can get a free clinical breast exam. That means a provider, usually it can be a nurse practitioner or a physician, will do a breast exam, will do a pap smear. And then if they find something or they're at the age where they need a mammogram, it's a paid for, it's a state funded program that pays for that. I also work for a federally qualified healthcare center in West Virginia, and I know there's one in Virginia right close to us. There are some in Maryland right close to us, and they all will see patients free of charge if they don't have insurance. And we can do pap smears and all those things, right? Everything that we can do in the office, and then usually we can figure out a way to get a mammogram. And it's usually through the health department. We can usually work with them. The thing with Black women, most mammograms are started at age 40 in the white population. In the Black population, the new studies out there say it should be started at 30. I don't know, Negin, have you also heard that?
Yeah, 30 to 35.
Yeah. So, and women need to know that, because if they don't know, You know, they may say, oh, well, I'm not 40 yet. I don't need to worry about it. Well, you do. And there's a lot out there I know about self breast exams too.
So I think taking advantage of convention center expos, those happen pre-COVID twice a year in DC area, in which they would do blood pressure screening. They would kind of get you plugged in to check your teeth, do dental screening, because that's super important for your heart health as well, having good dental hygiene. I also recommend going to medical schools, because medical schools actually have these free clinics that these medical students are working at. I'm not saying you're going to get bad care. They're they have mentors and everything, but the medical schools usually have a free clinic that can be available, as well as dental schools also have free clinics. The other place I say is in the DC area, Unity clinics are very common in terms of having free healthcare for anyone who really needs it or is poor, like low income. And also Medicaid programs. Look into those. You may qualify, without even knowing about it. So there's so many resources that people don't know about. And I think that comes from just not knowing that there's these resources. So we hope that from this platform, you guys tell people to look. If you hear someone doesn't have insurance, did you look into Medicaid? Did you look into the clinic? Did you hear about this expo that's happening? Because once you go to an expo, there's probably resources there that will say, okay, your blood pressure was 170 over 110. Let's try to figure this out and kind of plug you in with care.
And in West Virginia, we have something similar to your expos. We just call them health fairs, but they do DEXA scans, free DEXA scans. They do, blood pressures. They do blood sugar checks. They do cholesterol checks, lots of things. But if people don't know they're there, and that's how we can help to get this across so people can find out.
Yeah, absolutely.
For breast cancer and breast awareness. So we as OBGYNs highly recommend you be breast self-aware. So you should look at your breasts, you should know how they feel, you should know what is right, and then you should be aware of things. You can do breast exams, that's totally fine. If you find a lump, you can come in and make sure, but you want to make sure that they feel right to you. So what we say is look at them in the mirror. Don't be afraid to look at them. Don't be afraid to touch them. Go know you're normal so that you can identify when something's abnormal. If you see a dimpling in your skin, if you see a retraction, if you see one's higher than the other, that's sometimes normal. But if you see something's changed or you feel a lump, those are reasons to come in. Don't be afraid to examine your body.
Yeah. Do you find that amongst, Black patients that when you've asked them, do they examine their bodies? Do they stand in the mirror naked? Do they pay attention to those things? Do you find that many don't or many do?
It depends on the patient. I can't generalize, but I would say that most people don't do self-breast exams, don't self-breast awareness.
Okay.
I agree.
We all are hearing it tonight. Those who are listening, it might not be you because you may be the one who do self breast exams, but somebody may not. And so share this information with them. That is super important. Talking about getting checkups, I'm curious to know as a preventative measure, how often should women be getting checkups from primary care, from OB or GYN throughout the course of a year?
Well, in primary care, if you are healthy, as we've been saying, you need to at least have a yearly annual exam, blood work, get any screenings that need to be done, those things. But most of the time somebody has something wrong, hypertension, diabetes, whatever it is. I normally see those patients, if they're stable, every 3 to 4 months. You should be seen. We need to check your blood work. We need to make sure your kidneys are okay, that your liver's okay, that your cholesterol and all those things are normal. If they're not, then we need to make some changes in lifestyle and possibly medications. But, it's just really important. It's the only way that we can take care of patients and try to get the screenings to try to prevent, a stage 4 cancer, which is the worst cancer there is, or, someone at age 35 or 40 having a heart attack. And it does happen. It very well does happen. I just had a patient 36 years old with a heart attack. So And I'll let you answer about the OB/GYN piece.
Yeah, so we recommend annual exams in the OB world. And I would say most people think of their OB/GYN as their primary care doctor. So if that's the only doctor you see, most doctors feel comfortable with that and they will refer you if you don't. And if you feel comfortable with OB/GYN, it's okay to tell them like, hey, I have this problem. Can you tell me who you trust for me to go to? The other thing is that I would say is that you don't always need a pelvic exam per se, but it's good to check in to make sure that there's nothing going on. And I think the breast exam is usually part of that. And we will do a pelvic exam if we need to and if it's indicated. I would say that you definitely want to make sure that you get tested for STDs. I want to make sure that, those things cause cancer too, right? HIV, HPV, getting your Gardasil shot that can prevent you from having cervical cancer. Those are all super important. And so your OB/GYN can also be your primary care doctor or guide you in that direction.
So we talked a little bit about hypertension. And then now that we've gotten into the cancers, we kind of focused a lot on breast cancer, but what are the other cancers that seem to be affecting women particularly? Maybe what's second under breast cancer?
I think because I specifically looked that up, it was breast cancer and then colon cancer, lung cancer, and cervical cancer are the highest 4 in that order in Black women.
Okay, so Doris, those 4, unlike diabetes or hypertension, we can do things to cut back on sodium and exercise. What about those 4 you mentioned? How do you know before it's too late that you have some abnormalities?
Okay, for instance, I think earlier I said something about Black women, especially teens, 1 in 5 are smoking. It's definitely predisposes them to cancer. Now, not everybody that gets lung cancer is a smoker, but smoking is a very, very, very significant high risk for lung cancer. So they're already predisposed, by having the higher risk in smoking. And, that's one way that we can help with the lung cancer is try to get them to quit smoking. Try to get people to not smoke around them. Secondhand smoke can be just as deadly.
So Dr. Doris, let me ask you this really quick, because smoking, I want to make sure we're talking about all forms. Is it just cigarettes or is it the vaping? They got those vape pens out. Is it weed? Is it pipes? Is it all of that?
It is all of that. It's, vaping. We know vaping's a big issue. Marijuana is a big issue. All of those things affect the lungs.
Okay.
Now other kinds of tobacco, oral tobacco, affects more the mouth, the throat, those kinds of things than it does lungs. I'm not saying it doesn't affect lungs, but it's more mouth and throat cancers. But, and like with colon cancers, getting the screening for colon cancer, if they won't do a colonoscopy, which I have to say, and I tell people this all the time, I was one of those people, and I'm a provider. I'm one of those people that didn't go when it used to be 50 years old. I was 52 when I got I was afraid. And I went there and had it done. And I was like, I sit there and watched the whole thing on a camera, never felt a thing. I kept looking behind me to see if the doctor was still there. And so it's not so horrible as, it's been made out to be. And I think that's part of education. And if someone I've had patients that were just scared because of anesthesia. And you get very little anesthesia, but you do get some. And, I've had them do the Cologuard or do fecal testing for blood. It's little, they just put some on some cards and bring them into us and we screen them that way. And then if they come back positive for blood, then we send them, we can say, hey, you really, really need to have this colonoscopy. You should not have blood in your stool.
Yeah, I want to go into a couple of questions in the chat. First, I want to give a shout out to Sherry, who's in the chat and just mentioned that she's 9 years cancer-free, breast cancer-free. That's amazing. I mean, that should be celebrated, right? Every day of your life, you should celebrate that and tell somebody that you're free from that. So congratulations, and I'm certainly that the prayers were with you. There's a question here. I was told by a primary care physician that you don't need a regular pelvic exam if you've had a hysterectomy and are not sexually active. Is that true?
So if your hysterectomy, so there's two things. If your hysterectomy took out your cervix, that's true as long as the reason for your hysterectomy was not a cancer or any type of lesion on your cervix. If it was for abnormal uterine bleeding or if it was for fibroids or anything like that, yes, you don't need it as long as you don't have a cervix. Some people don't know if they have a cervix or not. So that's important for someone just to examine to make sure. But if you had a hysterectomy for non-cancer reasons or non-premalignant lesions on your cervix, then you don't need a pap smear.
Okay. So how often should you have a pap smear or pelvic exam if you've had a hysterectomy?
If you've had a hysterectomy and you didn't have those history, you really don't need it unless you're symptomatic.
Okay.
But if you've had it for cancer,
Yes, if you've had it for cancer, then it's about every 1 to 3 years. It depends on the kind of lesions you have.
Okay. Okay.
Yeah.
and and I think you said it was Sharon was the
Yeah,
lady
Sherry.
speaking.
Sherry in the chat.
Yeah, and one of the things that I found, the survival rate for Black women with breast cancer
Mhm.
is a lot less than counterparts in the white women. It's they have a 5-year survival rate that's only 71%.
Mm.
That's so, detection and screening, I can't stress that enough for any of these things, whether it's hypertension, diabetes, whether it's the cancers. The screening is what can, the earlier things are caught, the better chance of survival.
Mm-hmm. Mm-hmm.
And I'll say, I mean, like, we don't have anything for ovarian cancer, right? We don't have a surveillance for that. And that's that can be a killer on its own. But when you have ways to find it, right? If you have ways to detect it, I think it's super important. It's your right to get those things done so that we don't get into this problem, right? We can't diagnose brain cancer very easily with surveillance, but we can do it with colon cancer. We can do it with lung cancer. We can do it with breast cancer. And those are leading causes of death. Why are we letting this happen? Why?
Yeah, screening is important. You're right. Doctors, what about, let's transition really quickly into strokes. We talked about heart disease, cancer, and now strokes is the third leading cause of death amongst women of color. How do you prevent a stroke? I hear that the onset is very quickly. What are the things you should be doing to not have that happen?
So, I mean, one of the big things, and I think we've said it over and over, is lifestyle changes, controlled blood pressure, your eating habits, controlling any heart disease. All of those things can lead to strokes.
So let's talk about strokes for a minute. What is a stroke? Maybe let's define that so that our listeners can understand maybe the steps to take not to have this happen.
Well, it stands for cerebral vascular accident. And what happens is there's a blood clot that develops and goes to the brain.
Mm-hmm.
And it blocks oxygen. Depending on how big the clot is, it can lead to death. Depending on where the clot is, depends on what's affected. So it could be one total side, it could be speech, it could be memory. Nagina?
Yeah, so I think it's not just a blood clot, it can be plaque. So that's diabetes, that's all gonna fat, cholesterol, that all affects your blood vessels. If it just goes up, very small vessels in your brain, your very precious vessels, it can clot it off and deprive them of oxygen. And that's what a stroke is, basically depriving an area of oxygen that leads to neurologic complications. I think not only changing the lifestyle, but also knowing the signs of stroke is important. So knowing if you're sitting with someone, all of a sudden you see a droop, you see confusion, you see an arm kind of limping, those are reasons brain is time is brain is what we say in medicine.
Time is brain.
Time is brain. So you need to get them to the emergency room so we can do fast action so that we can hopefully prevent any bad consequences from happening. Time is heart, time is brain.
So what are the what are the symptoms you
Many
mentioned?
times you may even see something as slight as somebody not being able to swallow well, or they can't chew their food.
Okay.
Strokes show up all different ways, but it's some kind of, there's a change in that person.
Is there a mild stroke where you could be experiencing a stroke while washing dishes and then you kind of shake it off and kind of move on? Or does a stroke affect you so bad where you're incapacitated and you may have fainted?
Can be either one.
You can have subtle ones.
Okay.
Yeah. And that's the scary part, right? So if you feel off, that's a reason to be evaluated. Don't wait on it saying like, oh, this happened a while ago. Now it happened a little bit again. There's something going on.
Okay. That's good to know about those three strokes. And now I want to talk about those three. And Negin, I know this is your area. Those three, heart disease, and then cancer, and then strokes, as it relates to women who are preparing for pregnancy, women who are in pregnancy, and women who have given birth already, right? How do those things affect those women?
So I'll first start with, if you've had pregnancy complications, such as preeclampsia, which, if people don't know, it's a disease of pregnancy in which the placenta kind of abnormally attaches to the uterus and causes the vessels to kind of be constricted, so it's tighter than normal. And it can lead to high blood pressure in pregnancy. That is what we sometimes call a window to your future. So a window to your health, window to your heart. So you have a higher risk of heart disease. You have a higher risk of heart attacks. You have a higher risk of strokes. You have a higher risk of diabetes. So having those complications early when you're in 20s and you had that complication in your pregnancy, you need to know that that has implications for you 10 years down the line, 20 years down the line. Just because it's happening right now and it's done and you deliver doesn't mean it doesn't have any problems later on. So that's why it's super important to every year to have yearly checkups. And we always recommend you to have yearly checkups for your blood pressure because you're at risk for blood pressure. And as we said, blood pressure causes strokes, causes heart disease, everything like that. In terms of having diabetes or having high blood pressure and preparing for pregnancy, you need to maximize how well you're controlled so you have a healthy pregnancy. So you don't have to have a preterm delivery. So you don't get a stillbirth. So your baby grows well. So you don't have complications like preeclampsia. So it's super important to meet with a high-risk doctor even before you're pregnant to say, am I ready for pregnancy? Because pregnancy is a big deal. Pregnancy has a big stress on your body and you want to make sure you're in the tip-top shape for it. So I think those are the biggest things that I would take from it, is that pregnancy can affect your later life and right now can affect your pregnancy.
And I have seen that in primary care. It's one of the things when I do a history is I always ask, did you ever have gestational diabetes, which means diabetes in pregnancy that developed in pregnancy? And have you ever had preeclampsia? Because I many times will have patients come in and they develop hypertension, a few years later. So it's a big part of history taking for us too.
Question in the chat: is preeclampsia more prevalent in women of color? I've known several African-American women who have died while pregnant.
Yes, unfortunately. So the risk of preeclampsia in the general population is 7%. In the African-American population, it goes up to 35 to 40%. Yes.
Wow.
And I believe isn't gestational diabetes higher too?
Yes, gestational diabetes, all preterm birth. Unfortunately, all the pregnancy complications are higher in women of color.
Another question in the chat: for pregnant women after delivery, why ask them to wait 6 weeks to be seen? Why not 3 weeks?
That's a great question. So actually, there's a big change with the American College of Obstetrics and Gynecology to change this 6 week rule to 1 to 2 weeks after delivery, 1 at 6 weeks, because we saw that we were missing so many people. We were missing so many opportunities for education. We were missing so many of these patients that we could have helped to prevent maternal death. So these are the reasons that we now call it the 4th trimester. So we have the first trimester, second trimester, third trimester. Now this postpartum period is the fourth
Mhm.
trimester, the big push. So
Mhm.
that's great. And I advocate for you guys, whoever is pregnant on here, to make sure that you get seen within 1 to 2 weeks after delivery. Get a blood pressure check if you had a blood pressure issue. Get a blood pressure cuff at home to make sure that you know that your blood pressure is fine.
Your experience, and Doris, you and Nagin have probably worked in city, suburban, rural hospitals, maybe all three. Is there a difference between environment as to what you've seen as top health challenges within women of color, or are they very consistent regardless of the environment that you're in?
I think it comes to resources. And I will say I came here from another city and we live in the nation's capital. And I will say that even at the nation's capital, there's a lack of resources. I'm appalled by it sometimes. I can't believe that I have to beg someone to give me a blood pressure cuff for a patient. So I think that the low socioeconomic status and the low poverty levels, I think they really get hurt hard. And so I do see a difference where I go, and I do see a difference with where I am. So
yeah, you're in a city, and Doris, you're in the countryside, right? So let me ask you this, because you're in the countryside. Do you see that white women are just as affected as women of color in the country?
Where I am, yes. I mean, it's so dependent on socioeconomic, things. Access is difficult. We don't have, I mean, we are lacking a lot of primary care providers, and there are a lot of nurse practitioners in West Virginia because of that. But, resources are really not good in the area that I am in. Now, when I was in Morgantown, that's a much bigger place. It's not city like DC, but much bigger place, and resources were more available. But if I have someone that I diagnose a type 1 diabetic, where I live, I have to send them 2.5 hours away to get with a pediatric endocrinologist. So, many of and transportation can be transportation is a big issue where I live. We don't have cabs and buses.
Ubers, you don't have that out there?
No, absolutely not. Wow. So if they don't have a car or someone that can take them to appointments, and if there's any financial strain, maybe they don't have insurance, they can't get their car tags, there's all kinds. Resources are a big issue.
And I will just say, I mean, when I hear patients have these barrier problems or have, if they tell me their problem, I can try to help as much as I can. If I don't know that there's a problem, right? I don't know that you can get to your appointments. And I don't know that you don't have food on your table.
Right.
And I'm embarrassed by it.
I think that exactly, they're embarrassed and they don't want to tell you. And I think that trust that you build with your patients makes that a little, I've had some patients after I've seen them for a little while that they start to trust me and they'll tell me things and I'll be like, oh gosh, I wish you had told me this last year when I started seeing you. We do have one little local, it's by the senior center we have here, that will take some people to appointments, but it has to be scheduled a week ahead. It has to be, there's all these requirements involved with it. But yeah, it's difficult sometimes. If we don't know, we can't help.
Yeah, if you don't be afraid to ask.
In the education system, I'm an educator, so I can only really talk about that. That's my lane. We always encourage our teachers, if they're having trouble getting parents into the building because of work, right, to go to the parents' homes or go to the community centers, right? So are there those type of opportunities where you send a van or you send a medical van or a medical car to pick up patients and bring them to the hospital? Does that exist?
Well, as I said, we have this one bus that with the senior center, and I think they have, I'm not sure, depending on their financial situation, they either pay $1 or they don't pay anything. But there are times our office has paid the $1. so we could get them in there. I do have several now, right now, COVID, with the COVID-19, I can't do it, but I have several patients that I do home visits on because I have a gentleman that lives in a second floor apartment that's an amputee. So he can't get out. He and his son that lives with him has no vehicle. He walks to the store to get their groceries. So I do home visits on him.
Doris, let me ask you this. If hospitals paid nurses and doctors to do home visits, right, as part of their salary, as part of, if you work an 8-hour shift or 12-hour shift and you do a home visit, that's maybe 4 hours, it'll count for a full day. Are there hospitals and organizations that do pay doctors and nurses to do home visits?
Well, my office, it's part of my, if I'm there 8 hours, I go, I spend usually, we have a certain distance we can go, and it's usually an hour visit. So you have to hone in on what's needed, and you can go more often if you need to, but I'm paid for that, as my salary, as part of my salary. But there are limitations to it. I mean, we can't do everybody at home, or we wouldn't be in the office. And, so there, we have to really screen the patients. We know the patients, we know that they can't get in, that they, I think we don't have more than probably a dozen that we do home visits on. We did have a little bit more than that, but we had some pass away. But, it's an option, ask if you need a ride, to an office appointment. There's sometimes things that offices have, like a little slush fund that they can use sometimes to get you somewhere.
And I would say, there's nursing, so not physicians, but there's nursing visits that come home and do blood pressure checks. I know in pregnancy, we have something called Optum that comes and, checks blood sugars and does, gives IV fluids if you have nausea and vomiting of pregnancy. So there are these nurse agencies who report back to a physician. So you don't need to have a physician there, but a nurse who can do everything for you. Also, a lot of the Medicaids cover transportation through Uber and Lyft now. A lot of my patients are coming with Lyft to their appointments, which is really nice, even with COVID. So if
we only had that.
Yeah, where you're at, Doris, you don't have that, but if you're in a city. But
that's great. That's the first I've heard of that. So yeah, there are ways, and like I said, we have even, this fund that we have even, put gas in somebody's tank, gas tank, giving them $10 to put gas in their car to come and bring somebody into the office and take them home. So there are always ways that we can try to help. We can't do everything, but we can do a lot if we know you need the help.
I want to get through just a few more of these questions in the chat. Dr. Doris, Dr. Negin, thank you so much just for your patience and your knowledge tonight. Not only have I learned some things that I'm sharing with every woman I know, but I'm hoping that everybody on this call shares this information as well. There was a question here about, let me jump back to it. How do we get healthcare providers to acknowledge and treat pain in Black women, knowing that many have expressed pain and have not been taken seriously? So this question really speaks to Black women having a voice.
Yeah. I mean, there was a recent research article about this in obstetrics, that we don't ask women of color their pain score compared to white women. So after a C-section, Black women weren't asked their pain score, but a white woman was. And, it all comes from this stuff being published so that providers don't have this implicit bias or this innate bias by accident, right? We don't want to be ill will to anyone, but it just happens. So I think the research and it being out there all the time helps. So with pain, I think, finding another provider if they don't trust you, or if they don't believe you. If you need to get another opinion, I recommend it, because your pain is real and your pain deserves to be treated. You don't deserve to be in pain.
And pain is what the patient says the pain is, not what the provider thinks it is.
Yeah.
So if you don't have a provider that believes you, I agree. Find someone else.
And the last question, I'll end with this. I'm grateful for this question. Actually, there's someone in the chat who's a pre-med
Oh.
major and hoping to use future career to alleviate healthcare disparities in any way they can. This is for the both of you. What do you all think will be the most important thing for the next generation of physicians to do, learn, or be mindful of as we begin to enter medical school and training?
I think knowing that the health disparities exist
Mhm.
is the most important thing. When you know health disparities exist, you then know that we need to find out what the cause is. So right now we said, okay, we have higher rates of hypertension. Why is this the cause? How can I treat it better with, in African Americans compared to white individuals? If you don't know it, then you're not going to know to study it. And I think medical schools are working on this because it's a big push now, because it's a big social deal. I mean, it's affecting our lives, it's affecting mortality. It's not fair. So I think being aware of it and then asking your preceptors to look into it with you, right? If you see a patient that you don't know what's going on and you think that they're being treated differently or they have something different, look it up and try to figure out together, because you're going to be teaching someone else who's not in your shoes right now.
Mm-hmm.
Well, and I will say, by teaching DNP, which is Doctor of Nursing Practice, family nurse practitioner program I coordinate at a university. We recently changed our curriculum, and it includes a course on vulnerable populations and a clinical piece to it, where we have a big Spanish population and Mexican population in the area. And and also, Black and other minorities too, but we have to know what the health disparities are with them so we can treat them. And so we've included that in the curriculum for the nurse practitioners, so that it doesn't get missed, because I agree, they have to know about it, have to be taught about it to be able to include it in their, when they get out and practice.
Mm-hmm, mm-hmm. That's good. That's good. You guys have been a just wonderful thought partners tonight. None of us could have read any of this information in an hour. And really, and Dr. Doris, you teach, these practices and these concepts, right? And so, as both of you think about some parting words, I just want to ask you this, Dr. Doris, and then I want you, Dr. Negin, to think about just some parting words. What are some of the things, Dr. Doris, that you are sharing with your students, right, when it comes to their own personal health as well as the health of others? Because I think that sometimes there's a distinct difference. They focus more on others than themselves. At least physicians probably do that, right? So in your class, do you walk your students through own self-care as well as what they should be doing for others?
Well, we do talk about self-care, and we do bring in, I mean, obviously it's how much the student wants to, say in a classroom setting with other students. But we have small classrooms, and they tend to be very vocal. And when we start talking about things, one of the courses I do is women's health. And when we start talking about some of the disparities in women's health, and I also teach a lot about hypertension and the disparities with, Black women and how you start them out on different medications. And you would be surprised how much stuff they share from their personal life. And, well, I never did this, and, I was okay, or I did this and you wouldn't believe what happened, and I think sharing those kinds of stories, and I share stories from, not that I say patient names, tell them where, because I've been in different clinics, different places. And I always share stories, that are very meaningful. When someone discovers all of a sudden, wow, I lost 50 pounds and I don't have to take, blood pressure medicine anymore.
Mm-hmm.
And now that doesn't always happen, mind you, but sometimes it does. It's weight related. Had another patient lost weight and didn't have to take any diabetic medication anymore. Had to still monitor their sugars, had to still change their lifestyle. But, you know, sharing those things and the students sharing their stories, you know, makes it real. It's not just me in front of a class talking and, you know, just giving them verbiage for them to remember, but it's actually understanding.
Yeah, that's really good. I appreciate that. Dr. Nagin, any last words?
I think my biggest thing is I always tell my patients to be your own advocate. So I can only do so much, but if you advocate for yourself, you're going to get the best care you can. So the only way to be an advocate is to know what you have and what you need to do, and to read and to be up to date on everything and to know what's important for you. And so your body is your temple, so you have to worship it. That's what I always.
Yeah, that's great.
And remember, the internet can be good, but the internet can be bad. You
Right.
have to have a reputable source when you're looking things up.
Yeah, great party words. Those who are still on tonight know that we do this every Tuesday, every Thursday. So stay close to your emails. This weekend we'll be sending out what next week will be. Dr. Nagin, Dr. Doris, my goodness, I just thank you both for just a wealth of information and knowledge that you brought to the community tonight. And those who could not make it, luckily on this platform, we have a replay button. And so those who by email tonight or tomorrow morning will get a chance to listen to all of the wonderful things that you said. So thank you again for your sacrifice.
Thank you.
Thank you for having us. Bye-bye.
Take care, everybody.